I did not catch.
Oh, you can read it.
All right. So respiratory emergencies, and again, this is what you're going to have to be really aware of for these kiddos. Okay, partial airway obstruction or complete airway obstruction, croup, epiglottitis, and asthma. What's the difference between a partial or complete airway obstruction? Hold on. Sorry, guys.
That would be my suggestion.
Okay. So difference between partial and complete. Ma'am.
Complete is a complete block of the airway. A partial may have some kind of airflow around or near the object that's obstructing.
Okay, we're going to learn a little bit about how we're going to treat complete and partial. Now, I realize that y'all took a CPR class and you had to learn the Heimlich, and they had some very clear definitions. We're going to have slightly different definitions as EMS providers, okay? So please kind of take note and pay attention as we go through this. All right, so partial airway obstruction causes can be anything. You see that this baby swallowed a earring. So sitting in alert, or is there stridor or crowing, or is it generally noisy when they're breathing? Are there retractions on inspiration? And do they have good peripheral perfusion? Okay, we absolutely still need to assess that. So treatments, position of comfort, usually sitting up, oxygen and transport. Don't agitate the child. Do a limited exam and do a quiet, easy ride to the hospital, generally. Okay? What I want you to understand is this is a kid that has a partial airway obstruction that is still effectively ventilating. Okay? So that's kind of what we're going to have to determine when we start figuring out how am I going to take care of this partial airway obstruction. Because a partial airway obstruction that has respiratory compromise, we're going to treat like a complete airway obstruction. Does that make sense? Okay. Complete and partial airway obstruction with poor exchange. Okay. So assess, is there ultramental status, stridor, crowing, or is it quiet? Okay. And then is there increased respiratory effort, poor chest wall movement? All right, that tells me, what does chest wall movement tell me? What am I looking for really when I?
They're struggling.
Yeah, so if it doesn't move much, there's not much air going in to get it to expand, right? We know this from when we're bagging. We're kind of going, is it moving enough, and am I getting enough air in? That's what we're looking at here, okay? And then, again, do they have poor peripheral perfusion? Then we're going to go with foreign body procedures, okay? The airway of a pediatric patient, and really most adult patients, can be kind of broken down into upper and lower airways, okay? Now, the sounds can too. Remember, the louder the noise, typically the higher the airway, okay? So your upper airway is going to be that stridor or crowing on inspiration. A lot of people will get audible wheezing confused with stridor. Wheezing is on exhalation. Stridor is on inhalation. Okay? And then lower airway, again, is going to be your wheezing, and then even rapid breathing without stridor. Okay? They can have rales and rhonchi too. So if you have a kid with a lot of pneumonia, the problem is that they have such little chests and they're so hyperresonant, it's going to sound coarse and it's difficult to differentiate between like rales and rhonchi. So the mucus and the fluid are really hard to differentiate in pediatric patients, but that wheezing is going to be the same. It's kind of like that whistle. Okay, is everybody with me? All right. So, croup. This is a viral infection of the trachea and the larynx. Okay? If you've ever been in Walmart and you've heard that thing that sounds like a seal bark, you go to the zoo. You know what I'm talking about, right? And it's that sounding cough. They have croup. Okay? Yeah. Yep. Oh, yeah. This is typically going to be ages 6 months to 4 years old. Okay? So when they talk about onset, it worsens at night. These kids have some signs of respiratory distress, The difference here is, while it comes on and it gets worse at night, when you talk to mom or question mom, the things that she's going to tell you are, he's had a cold for a few days, been kind of runny nose, kind of a cough, low grade temp. It just got worse tonight, so maybe 2 or 3 days. Tonight got worse. Okay? Put him in the position of comfort. You're going to administer high-flow O2 if you can. If you have the ability to humidify it, that's okay. All right? Cool air may provide some relief. Don't visualize the airway and transport them. These kids can have stridor at rest. So when a mother tells you, and a lot of times it happens like in the winter months, okay? So when a mother tells you, I didn't know what to do, they started making this funny noise every time they were breathing in, and he's been coughing, and so he was making this funny noise and he was coughing, and they're going to run out to the ambulance to meet you because they panic and they don't know. They're going to hit that cold air, and she's going to go, I promise he was really making this bad noise. And you're going to be like, whatever. It's probably croup. Because it helps with the inflammation. So my kid used to get croup all the time, and we had the whole stridor at rest, and they gave us steroids and stuff, and we'd go into the bathroom and turn on, get some steam going, get some humidified air going. Helped him significantly. Well, humidified. The difference is, okay, so what happens when you get cold? What happens to things that are swollen? Reduces edema, right? Infection causes edema or swelling. Well, it's different, but yeah, absolutely. Okay. Epiglottitis. Epiglottitis is a bacterial infection. Okay, so croup generally has to run its course. We're going to kind of treat the symptoms, which is why they're going to give steroids for the inflammation and not antibiotics. Okay? This is a bacterial infection of the epiglottis. Do you guys know what the epiglottis is? Do you remember what the epiglottis is?
A little flap.
It's the flap that covers the trachea whenever I'm eating or drinking something, which is why it's bad when you're laughing with food in your mouth or drinking. You're at high risk for choking, right? Because that flap is open. Okay? So the epiglottis in kids, it's typically bigger and more floppy, if you will, in comparison to the size. Okay? So they're pretty high risk, all right? So this usually affects ages 3 to 7. However, I will tell you that there's a higher incidence recently, even in adults, due to not keeping up with vaccinations and this kind of stuff. Okay? This is a sudden onset of a high fever. When I say sudden, I mean they were doing okay. This is within 24 hours they can have a complete airway obstruction. Within a few hours it can be a complete airway obstruction. Okay? These guys are going to have that tripod position. They're drooling. They're not swallowing. Okay? They are sick. They look sick. Okay? And, of course, respiratory distress goes along with that, right? So when the epiglottis gets swollen and inflamed, it has the potential to swell completely over and be inflamed so that it can't even move, and it completely blocks off the trachea. Well, the illness is going to be sudden, so they're going to start having some respiratory distress along with that fever. Yeah. I mean, this is pretty quick, where the other one is, oh, they've had a cold and a runny nose. You see what I'm saying? Okay. So what are we going to do? Put them in a position of comfort, high concentration of O2. This is an immediate transport. Do not stimulate. Don't cause anxiety. Don't do anything. Don't look in their mouth. This is truly an emergency, but this is okay, don't panic. I don't want this kid to be anxious. I don't want them to increase their metabolic rates. I don't want to increase their need for oxygen. I don't want to increase blood flow, because blood flow, okay? See what I'm saying? We got to keep them calm and cool and get them to the hospital.
So even though you would say transport immediately to emergency, you wouldn't run lights and sirens?
That's going to depend on how sick your kid is. Wholeheartedly, it's going to depend on how sick your kid is. So you're going to have to weigh. Do you know lights and siren might gain you 90 seconds to 3 minutes is all it's going to gain you. That's proven. If you're lucky, it'll be 3 minutes. And that's going to depend on your transport time. Yeah, you still have to stop and clear. So again, it's more important to keep my kid calm and relaxed and save that 30, 90, 60 seconds, whatever. Okay? Asthma. This is some scary statistics, guys. It affects about 7% of kids. Mortality is on its rise. We have about 100 kids a year that die of asthma in this country.
Really?
Yes. I am assuming resistance to, so we have more infections that are resistant to some other antibiotics and stuff, and we're going to talk that upper airway infections are bad juju if you have asthma. It's going to exacerbate your asthma, things like that, and otherwise I don't know. I mean, that's the only thing that I could think reasonably that would make sense. And sometimes it's not intentional neglectful. Sometimes it's we don't have health insurance because we work at these jobs and I don't have the money. And if I get their medicine, I can't feed any of the kids. You know, what am I going to do? Okay? So here are the three things that happen in asthma. Inflammation, muscle spasm, and increased mucus production. So it spasms and gets tight, and then it gets inflamed, which is swollen. So you take an already small airway, you squeeze it down a little bit, you swell it up a little bit more, and now you add mucus in it. Ooh-wee. Ooh-wee. Be careful if they say they took, say, Benadryl for allergies. That can cause asthma exacerbation because it dehydrates or it dries out secretions. So then essentially you're drying out this mucus and creating this big mucus plug. Okay? So what are we going to do? We're going to treat it with beta agonists. Typically it's albuterol. Give them supplemental O2. Be careful if you're using a BVM. First breath can really pop a pneumothorax, right? Because you're going to have increased resistance already because of those small, tight airways. So you got to squeeze a little bit tighter. So if you aren't paying attention, you're going to go, I got to squeeze, and you're going to squeeze, and you're going to feel some resistance, and you're really going to give it a good pop. Literally. Sir?
The difference between an MDI and albuterol?
Dose and route. That's it. Because a lot of times your MDIs are actually albuterol. Zopanex, same thing.
So use their MDI first. Is that what you're saying?
Not if they say it's
I'm
working.
not sure what.
It didn't work.
By this time, don't they? You've already, like you said, your son uses his, and then
Usually they've
This is past that phase.
most of the
Wait,
time.
Okay.
Most of the time. I realize for National Registry you still have to know it. But
All right. So
This is your-
We're getting called to an asthma call. They've already attempted their inhaler. And
maybe. They may not have it.
Ask them.
It may be I'm out of medicine.
Okay.
Yeah, or I've lost it. Again, my son, his asthma is allergy-induced, like seasonal allergy-induced or infection-induced. So he won't have to have it for 6 or 9 months out of the year. So when it comes time for that first time, has he kept up with it? Have we all kept up with it?
Expired or something.
Yeah, absolutely.
I was just curious what the difference was.
Yeah. So you need to think long. You need to really take time and squeeze it long. It takes about 1 second to deliver a breath, and it should take 2 seconds for them to exhale. Okay? What do you think happens if wheezing stops? Well, now you can still help it, but they're in big trouble. So we're gonna clamp down, and we're gonna wheeze, and we're gonna wheeze, and we're gonna wheeze, and eventually it gets so small that it can't whistle or wheeze. Okay? So it's not uncommon that if I listen and go, they're tight or they're not moving much air, try to give them some albuterol, they may start coughing like crazy and wheezing again. That is a good thing, because at least we're opening the airways a little bit. So think about, when you think about wheezing and asthma and how it works, think about, how many of you guys can whistle? When we open our mouth wide, right, and we breathe, we don't whistle. It has to be against a narrowed kind of opening. But make your opening pursed lip too much. Do you wheeze or whistle? No, because it's too small. Okay? That's the process in which this happens. Try it. Okay? So the three things that happen, again, are inflammation or edema, swelling, muscle spasm, which is why we give that muscle relaxant, right? And mucus plugging. Okay? So So categories of respiratory dysfunction. We kind of talked about this a little bit already. We're going to have respiratory distress. So that's when they're going to have increased work of breathing, but they're maintaining adequate oxygenation, okay, and ventilation both. And then if they're in failure, compensatory mechanisms are just that. They're failing. So they're going to have inadequate oxygenation and ventilation, okay? And then respiratory arrest is basically absence of breathing. A lot of kids will go into status, and status is a big problem when you're talking about asthmatics. Status is the kind of thing that you can't break. These kids will be in the hospital on continuous nebs. They continue to spasm, okay? They get IV drugs and all kinds of stuff. All right, respiratory distress. Nasal flaring, stridor, audible wheezing. Retractions are both between the ribs at intercostal, above the clavicles, which is that supraclavicular, and then below the ribs is that subcostal retractions. We kind of saw examples of those today.
I'm kind of confused on what retractions are. Is that when you're trying to suck in, but the lungs won't inhale, but other places suck in?
It's when the, okay, so if these are ribs and these are muscles, they suck in when you breathe.
Oh, the muscles come in.
Yeah. I'll show you. I'll pull up some on YouTube because you can really see some good retractions on YouTube, and you'll know when you see what retractions are. So I'll pull some up so you can see it.
The ribs come in as well.
Well, think about your rib cage.
Okay, yeah, it's fixed in place, right?
Yeah.
So,
Because remember, my muscles are tight.
right. Does that just basically mean that you're pulling extra hard in?
Yes.
All right.
Yep. Trying real hard.
I'm glad you asked that.
To pull in. Okay. And then you can have use of neck and abdominal muscles, again, depending on how old the kid is. You may or may not be able to see them using their neck. Young kids will head bob. Some of them will grunt. Okay. Grunting, again, sounds like a expiratory cry. Like every time they're, it doesn't always sound like a true grunt. Okay. And I think I might have some audio of that as well. So nasal flaring, look at the difference here in this baby and that baby. Look at that. That is a true retraction. Sometimes, and there is YouTube video, and I really want to play it for y'all, that this baby collapses their chest almost half of the diameter.
That's
It is, yeah, it is quite alarming. Yes, it does. Remember, there's subclavicular, intercostal, and subcostal retractions. So it happens in various places. Okay? Then it's use of accessory muscle use or belly breathing. Well, yeah, and what you're going to look for more is kind of like that seesaw breathing. How much are they pulling with their abdomen? Okay? Respiratory failure. Look at this baby. See that? This. See that? Also, look at the way the baby's laying. Not engaged, kind of checked out. Okay? So, tachypnea, which is what? Cyanosis is?
the blue.
Okay? Decreased muscle tone. Look at the way the baby's arm is just flopped over, that top arm. That's what we're talking about. When we looked at that in that kid that probably had meningitis, the muscle tone was just kind of there. Okay? Altered mental status, again, not engaged here. Grunting is that expiratory cry or grunt. And then use of accessory muscle use and retractions. Respiratory arrest is you're considered arrest at bradypnea, which is what? Too slow breathing. Okay, limp muscle tone, unconsciousness, bradycardia, and weak distal pulses. This is all considered respiratory arrest. So what are we going to do? High flow O2. Ventilate for severe respiratory distress. Okay. Respiratory distress with ultramental status, cyanosis with oxygen. Okay. Poor muscle tone or respiratory failure. All of those. Okay. We're gonna ventilate. And then albuterol for bronchoconstriction. Here's what I'm going to tell you. If you kind of go, do you think we should bag this kid, or I don't know. If you're thinking it, probably need to think, if this kid looks sick enough that I kind of question, do I need to? Okay? And if they tolerate it, definitely need to be bagging them. Well, for newborns, it's under 60 Heart rate's under 60. Again, look at the wide range of heart rates, depending on how old the kiddo is. Always, always, always go with oxygen first. Typically, if a kid has a low heart rate, it's because they need oxygen. Their hearts usually are very strong and good, right? It's the respiratory compromise that will end up causing that failure. So typically, if you address the respiratory stuff, the rest will kind of fall into place. It will kind of follow suit. Right, and that's for newborns. That's your newborn resuscitation inverted triangle. Okay? All right, seizures. These can be life-threatening, and they may be brief or prolonged. So how long do you guys think a true seizure typically lasts?
A couple of minutes.
About a minute. Typically, it's usually even less than a minute for most. Okay? But that minute seems like a very long time. All right?
I had a patient that had one for the first time ever, and her grandmother said it lasted for 10 minutes.
Sometimes.
But it didn't. I mean, the other people around were like, it wasn't 10 minutes. But she
It
panicked.
feels like forever. Okay? So what am I going to do? Assess for respiratory distress, and also were there injuries caused by the seizure, because remember, they may flail around. It's typically not as exaggerated as what we like to think, okay, but it could be. Or how about, were they standing up when they fell, and did they hit their head, kind of stuff, all right? Do they have a history of a recent fever? Do they have previous seizures, and if so, is this the same? Does it look the same? Kind of stuff, okay? And then are they on medications for seizures, and are they taking their medications? Also, something you want to know is, are they sick? Right? Because what happens? When you get sick, you have a fever. When you have a fever, what happens to your metabolism?
Stresses you out.
What happens to my metabolism? It goes up. Well, what happens to my medications when I increase my metabolism? Yeah, you start to burn it off a little faster, so they may not be in that therapeutic levels. Okay? Some causes for seizures. There are a lot of them. Okay? Fever, infection, poisoning, metabolic disorder, bleeding into the brain, low level of anti-seizure medication, hypoglycemia, hypoxia, cause it on everybody, okay? And then idiopathic, so basically some unknown causes. Anytime I'm going to an infant seizure, let me back up. There's a couple things I tend to think of right off the bat, and we'll talk more about it in non-accidental trauma, but let me tell you that people who, babies who have shaken baby, they don't call for the shaken baby. It causes that bleeding into the brain that an hour or several hours later, the baby starts to seize, and they may or may not realize that that's connected. Also, just because whoever called doesn't necessarily mean that's who the culprit is.
Right. If you take somebody else's seizure medication and you've never had a seizure, can it cause you to have a seizure?
I don't think it lowers the seizure threshold, but things like Wellbutrin lower your seizure threshold. So people who don't have seizures who take Wellbutrin could very well have a seizure.
What about gabapentin?
I don't know.
Okay.
Don't know. All right, febrile seizure, this is typically a response to an infection, okay? This occurs when the temperature suddenly spikes. It is not about it got too high. It's that it went up too quickly. Okay, I've actually seen a kid seize at like 101, which isn't really a very high fever. Okay, it's all about how quickly it went up that way. Okay, it does usually occur though over 102, but it just depends. Typically, if a kid has febrile seizures, it's not uncommon for them to have them whenever they're sick, but usually they only have one febrile seizure per illness. Okay, so what are we going to do? Airway position and patency is important, so put them on their side if there's no trauma. Suction as needed because they're going to have some secretions. Some people even bite their tongue when they seize, so you may have to suction the blood out of their airway. Okay, high concentration of O2 is pretty important because when they seize, if they have a full body tonic-clonic type seizure, okay, they are not effectively ventilating. Huh? In general. Well, yeah, oh yeah, suction, I cannot tell you enough to suction. Make sure you don't suction too long and some of this stuff. Okay? Ventilate if respiratory distress or arrest, and then request ALS if they're actively seizing. Okay? And then transport. Anybody who's still actively seizing typically after we get there is in trouble. Again, seizures don't last very long. And then there's a condition called status epilepticus. Okay? Did we learn about this in adults?
Yes, we did. Where they don't have any difficulty.
Right. They don't return to baseline. Okay? Either they don't stop seizing or they do not return to baseline after 2 or 3 seizures. Okay? So altered mental status. Don't forget about your AEIOU tips. Okay? So causes hypoglycemia, poison, post-seizure, infection, head trauma, hypoxia, and hypoperfusion. Typically, if they're hypoperfusion, they're going to have one of the other things unless it was a significant trauma. Okay? So what are we going to do for altered mental status? Make sure they got a clean, clear airway, high concentration O2, ventilate them as needed, check the blood glucose, obtain a good history and transport. All right. Poisonings are absolutely a common reason for pediatric calls. Everybody know the number to poison control?
No, it is with 22 something. I have no.
No. And it's not uncommon for not only EMS providers, if they know what their patient took, to either call in advance. Guess what? ER is called poison control. Poison control can tell you things like, what color was the pill, what are the markings on it, what's the shape of it. They can probably tell you what they took if you don't know what they took. It'll also tell you what to watch for, common side effects. Parents will call, and poison control can tell them you don't need to go to the hospital. Or, I'm calling EMS, stay on the phone with me. Okay? So what was taken, how much was taken, how long ago was it taken, and what was given prior to EMS arrival? 1-800, I think it's 222-2111, I think. Is
It's
it?
on one of our slides.
Oh, is it? Okay. I thought it was. I figured it would be on this one. And then bring sample to the hospital if you don't know what it was. There you go. Oh, I'm sorry, 222-1222. So what are you going to do? Clear and maintain the airway. High concentration O2, assist ventilation is needed. Transport. Consider activated charcoal and contact poison control center. Okay, because they're going to tell you this is going to be, watch for this in the respiratory, or this is going to affect the cardiac. They can tell you what to anticipate. Going back to this, you need to assume that whatever's missing was consumed by, you have to assume that they took it all. Okay, because if you don't, it might kind of get you in trouble. So, yeah, I don't care if it was bleach or peroxide or Drano, whatever, and if it's all over their clothes, you can't go, oh, but most of them probably got, I don't care what it was, assume that they took whatever is missing out of whatever container it is. Okay? Fever. This is very much a common reason for pediatric calls. This is rarely life-threatening, especially the fever in itself. It's usually a result of an infection. Now, there are some caveats to this, okay? So little babies, newborns, neonates, any fever, they got to go to the hospital, okay? So fever with a rash is meningitis, and then treatment equals transport, and then it can cause seizures. We know this. Okay? Questions on that?
Poison control, is it for the family to call, or
I'm telling you,
EMS provider we can call? Just
the ER will call.
Okay.
They are the expert in toxicology for poisoning. They can help you, and they're there for not even for emergencies. They can help you with proofing your house or something. I mean, they can give you a lot of input. They're no, they're there for educational purposes as well.
I wanted to make sure that as a EMS provider, we weren't supposed to be assumed to know everything and how to fix it.
The ER physicians call poison control.
Okay.
All right. Fever is considered to be an emergency in any child if it's over 104. Okay, 101 in an infant that's less than 3 months old. And in fact, I think they say actually 100 or 99 is considered in a newborn because they don't have the immune system. Okay, it's something that kind of develops. And again, This is relative, okay? And I can only speak from my personal experience. It wasn't uncommon for my son to get 104 temp with ear infections routinely. My daughter only went up to about 102. So you got to kind of, what's the condition and situation? But you do need to assume that, okay, they're relatively sick. You know, I don't know. Well, and it depends because the babies can't, so the NICU babies can't regulate their temperature, so it has to be warm enough to keep them at an appropriate temperature.
They use a
So it's,
I used to use one all the time when I used to draw blood. They don't get that hot. I mean, they typically have 4 settings, and they leave them on like 1 or 2.
but the temperature regulation is based on the baby, not the environment.
What they'll do,
I anticipate it was probably warmer than 98.7 for her to maintain a 98.7 body temp.
what they do,
But that's what they're looking at is what's the baby's temperature.
they use a probe that uses like a
Mhm.
sticky, and it'll constantly tell them what the temperature is. And if the baby gets too warm, it'll alert so that you can turn down the heat. So the doctor usually gives them a rate at what the temperature is allowed to be at. So that way you don't, because you can burn them with those lights.
Well,
If
sure,
they get
it's
really
driven by
hot.
the baby's temperature.
Yeah, but it'll alert. So if it was doing something it wasn't supposed to, it'd go off.
Yep. Hypoperfusion. So some common causes, and we talked about this, especially with pediatrics or especially little babies. Vomiting and diarrhea, infection, and trauma can all cause hypoperfusion. Okay? Dehydration in little guys who are sick. Vomiting and diarrhea will do it. Okay? Less common causes, allergic reaction, poisoning, and a cardiac event. Cardiac events, if they're going to cause it, this is typically a heart condition that they were probably born with. All right, signs and symptoms, hypoperfusion, rapid respiratory rate, pale, cool, diaphoretic skin, weak or absent peripheral pulses, delayed cap refill, okay, kind of all the same stuff we look for in adults. Decreased output, urinary output. I always say, how many wet diapers do they have? If the baby's crying and not making tears, I'm concerned. If they have a sunken fontanelle, concerned. Okay? And then kind of what are their mucous membranes like? You know, is their snot real thick? Because typically they're going to have some sort of cold or whatever. Is their snot real thick, or is it like clear and running out their nose? That make sense? Because the less water that a person has, the thicker the mucus is going to become. Yeah. Yep. That's why you have to take a lot of water on, like when you do Mucinex and stuff. So what are we going to do for hypoperfusion? Ensure the airway is open, high concentration of O2, be prepared to ventilate, okay? Control bleeding. If it's a bleeding problem, elevate their legs, keep them warm. Spinal motion restriction if it's needed, and transport. Do a detailed assessment and route. We're not going to hang around and wait if this kid's already showing signs of hypoperfusion.
How do you elevate babies' legs? Aren't they kind of...
No, put a towel underneath them.
Oh, okay. That's enough elevation?
Sure.
Okay.
All right, near drownings. So consider the possibility for trauma, of course, and hypothermia, and then alcohol in adolescence. Okay, make sure somebody didn't steal a cooler at the lake. Okay. Protect the airway. Suction is needed. Artificial ventilation is going to be your top priority. Okay, let's try to push some of that stuff out of there. And then there's that secondary drowning syndrome that happens, minutes to hours afterwards, and that's that flash pulmonary edema that they're going to get. They're going to be in pretty significant trouble. Okay? Sudden infant death syndrome. Oh my. So this is sudden death basically without any identifiable cause in any kid less than a year old. When I say no identifiable cause, they've sent tons and tons of kids for, yes, thank you, autopsy, and they find nothing. They find nothing. They really don't know. So that's why when they kind of talk about how do you lay the baby, they know that there's a lower incidence when they're laying on their back versus their belly. They know that, I believe, boys are higher risk than girls. They know, so they know some of that, okay? They really don't know. Okay, it's just not well understood. This is very common in that early morning time. They put the baby down, they go to sleep, they think, oh, the baby slept all night, and then the baby actually died at some point in time, overnight. Huh? It's far too common, unfortunately. It's a sad thing. Try to resuscitate unless there's signs of obvious death. We're talking rigor mortis and lividity. Okay? Avoid comments that blame the parents. Guys, there is no known cause of this. None. Now, unfortunately, EMS also goes to far too many suffocations, and that's different than SIDS. So the co-sleeping stuff that somebody rolls over on the baby and they don't wake up. Mark has been on a call. I'm so glad I didn't get the call. The baby was sleeping with the 7 or 8-year-old sibling, and they rolled over on the baby, and the baby died. Okay? SIDS is very different, and whether you're there for a co-sleeping suffocation type issue or SIDS, this is very important. Okay? Avoid comments that blame the parents. Imagine for a second that you are that parent that just lost their child. I mean, do you not think that they feel the most undescribable pain and sorrow and loss as it is? I mean, what are you hoping to accomplish with those types of things? Be cautious even as you're entering or exiting the house. Okay? They're going to be in emotional distress, agony, remorse. Even if they know, here's what they're going to tell you. I knew I should have got up and checked. I should have. It's my fault. If I would have got up and checked on him, you know. And remember, some moms are up, or dads are up several times a night. And so by the time they get to sleep, and that baby's kind of their alarm clock, right? So sometimes when they get the opportunity to sleep, they don't even realize they've been asleep all night. Okay? The baby, the alarm didn't go off, they didn't wake up, they are going to feel guilty. I should have went and checked. If I'd have checked, I could have saved them. Okay? Questions?